Okay, so the next topic we are discussing is the glomerular diseases. I've covered this at the end because I've divided it into two parts. Also, it's a little bit complicated. I couldn't just pick one entity. I had to explain it to you all because otherwise it wouldn't make sense if I was just explaining one entity that you could just read from the book also. So we'll first see a brief outline of the structure of the normal glomerulus and then the list of glomerular diseases in nephritic syndromes and nephrotic syndromes. So we know this is the glomerulus, then we have the Bowman's capsule, and then we have the proximal tubule. We know that, right? So again, this is the glomerular with its afferent and efferent arteriole and Bowman's capsule, and we have the tubule, the PCT. Now when we give a cut section, a transverse cut section through it, this is what you see. This is the outside, this yellow thing is the parietal epithelium, and then we have these let me try by marking. Yes, okay. So this yellow, this is your epithelium, parietal epithelium. These are your capillaries. These are the lumen, the central empty space is the lumen of the capillary, this of your capillaries. This is your RBC in the capillaries, and the cells lining these capillaries are your endothelial cells. So this is the endothelium, and this we have the mesangial matrix. Again, this is your cut section of your afferent to, this is your afferent arteriole, this is your glomerular, and if you take a cut section, this is your epithelial cells. These are called your podocytes. This is the podocyte foot process. Then you have the glomerular basement membrane, which we'll see what it is made up of. And then you have the capillary, which is made up of any blood vessel is made up of endothelial cells. I hope you know all that. All the blood vessels are made of endothelial cells. And then we have the mesangial cells, the matrix, the mesangial matrix. Okay. So the structure of the glomerulus is there is an anastomotic network of the capillaries. Then we have the visceral epithelial cells, and then we have the parietal epithelium. So this is the glomerular capillary wall is the filtering membrane, and it consists of fenestrated endothelial cells because main is the capillary. Then we have the glomerular basement membrane. Then we have the visceral epithelial cells, the podocyte, and in between the capillaries we have the mesangial cells. Now if you see, the first layer is of your epithelial podocytes, and then you have the glomerular basement membrane. The third thing is your endothelial cell. The first layer is of your epithelial podocytes. Then you have your GBM, glomerular basement membrane, and then you have your endothelial cells. Glomerular basement membrane itself is made up of lamina densa, lamina rara interna, and lamina rara externa, and it is composed of collagen, mostly type 4, laminin, polyanionic proteoglycans, mostly heparin sulfate, fibronectin, intactin, and other glycoproteins. Now coming to glomerular diseases, they can be primary glomerulopathies, which is acute post-proliferative glomerulonephritis, which can be post-infective or otherwise. It can be RPGN, rapidly progressive crescentic glomerulonephritis. Then we have membranous nephropathy, minimal change disease, FSGS, or focal segmental glomerulosclerosis, membranoproliferative glomerulonephritis, which is MPGN, dense deposit disease, IgA nephropathy, and chronic glomerulonephritis. And then of course there are systemic diseases which are associated with specifically glomerular involvement, which is your SLE, diabetes, amyloidosis, Goodpasture syndrome, microscopic polyarthritis, vaginal, henoch-clonine purpura, bacterial endocarditis, and hereditary disorders like Alport syndrome, thin basement membrane disease, and Fabry's disease. Now if you look at the entities, among the nephritic syndrome we have acute post-streptococcal glomerulonephritis, RPGN, and something called as IgA glomerulonephropathy, which is Burgess disease, and your Alport syndrome. They all have the nephritic presentation. And the nephrotic ones we have FSGS, membranous nephropathy, minimal change disease, amyloidosis, and diabetic. And both presentations can be seen in diffuse proliferative and membranoproliferative glomerulonephritis. Now coming to the differences between glomerulonephritic and nephrotic. So nephritic usually have, first let's talk about the nephrotic one. We know the proteinuria, the nephrotic range. We have proteinuria, we have edema, which is retention of the fluids, and of course hypoalbuminemia, and then we have hyperlipidemia, lipiduria, and protein casts. Then we have your nephritic presentation, which is oliguria and hematuria. RBCs are present. It is non-selective proteinuria, because in this one, selective means selectively just albumin is deficient, or deficient in blood, which is hypoalbuminemia, and it is now coming in the urine. GFR decreased, BUN increased, edema, hypertension, RBC, and protein cast, not just protein cast. So the glomerular disorders can be acute nephritic syndromes, RPGN, nephrotic syndrome, chronic renal failures, and it can be asymptomatic as well. Now this is the list of all your glomerular diseases which is given in your Robbins. We'll go in these diseases one by one. I've made 2 PPTs for this. So first we are discussing only 4 entities. Then we'll discuss the rest of the entities in the second one, which I'll upload later. Coming to the nephritic syndromes. So these are diseases which present with a nephritic syndrome, glomerular diseases, and they have inflammation in the glomeruli. Their presentation, because it is nephritic, they will have hematuria, red cell casts in the urine, there will be azotemia, oliguria, and mild to moderate hypertension. Proteinuria and edema are common here, but not as severe as we see in the nephrotic syndrome. Now first entity is the acute post-streptococcal glomerulonephritis, PSGN. So there is diffuse proliferation of glomerular cells associated with the influx of WBCs. So there is an infection, post-streptococcal infection. So patient has a sore throat. So what will be the presentation? Your patient will be saying, I have sore throat, and after a few weeks the patient will develop glomerulonephritis, because so what is happening is, when he develops sore throat, this influx of RBCs is causing diffuse proliferation of glomerular cells. How? This is an immune complex mediated mechanism. We'll discuss it later. Then inciting agent can be exogenous, which is post-streptococcal glomerulonephritis, which is your streptococcal organism, or your endogenous cell, SLE, etc. also can induce the formation of immune complexes. In PSGN, the occurrence of this is happening 1 to 4 weeks after a streptococcal infection of the pharynx or skin, which is impetigo. Whenever skin infections are associated, infections are present, they are usually associated with overcrowding and poor hygiene. And post-streptococcal is usually occurring in children 6 to 10 years of age. The causation again is certain groups of group A beta hemolytic streptococci. So the latent period, which is occurring between the infection and the onset of the nephritis, is compatible with the time which will be required to produce the antibodies, and hence again the immune complexes against the antigen. Elevated titer of antibodies will be seen in blood, serum complement levels will be low, and deposits will be present. These are granular immune deposits in the glomeruli, which indicates an immune complex mediated mechanism. So if this is your normal, on the left side is your normal glomerular basement membrane, and then here you have your acute post-infectious membrane, and the immune complexes are deposited over here. If you see, these are immune complexes deposited. So these are subepithelial. Okay, enlarged hypercellular glomeruli. There is proliferation of the glomeruli, and there will be leukocyte infiltration, and it is typically global and diffuse. Endothelial cells can be swollen. There can be combination of proliferation, swelling, and all of this can obliterate the lumens of your capillaries. There are subepithelial humps of the GBM. These are subepithelial, these immune complexes causing subepithelial humps of your GBM, and there are granular IgG and complement along the basement membrane in association with these above humps. So this is on A is your normal glomeruli. So in comparison to this is such a hypercellular and proliferated one. And if you see this blue discoloration, blue colored cells, these are usually your WBCs. So what is the clinical course? There will be a young child having sore throat. After 1 to 2 weeks, he'll present with malaise, fever, nausea, oliguria, and hematuria. And on the examination of his urine, you will see dysmorphic RBCs or red cell casts. There will be mild proteinuria. The patient will have periorbital edema and mild to moderate hypertension. In adults, there can be sudden onset hypertension as well. Lab finding will show you anti-streptococcal antibody titers have increased, serum complement levels have decreased, and more than 90% of the children will recover normally if you give them conservative therapy. Next entity is your rapid progressive glomerulonephritis. It's called rapid progressive crescentic glomerulonephritis. Why crescentic? Because in the glomeruli there is crescents present. So there is, as its name indicates, there is rapid and progressive loss of renal function associated with severe oliguria, and there are signs of the nephritic syndrome. It's a nephritic entity. The most common histological picture is the presence of crescents in most of the glomeruli. That's why it's called crescentic glomerulonephritis. Now these crescents are produced because the proliferation is happening of the parietal epithelial cells, and also monocytes and macrophages are also coming there. So rapidly progressive is divided into three types. Type 1 is anti-GBM antibodies. So the antibodies are produced against the glomerular basement membrane. It can be renal limited or Goodpasture syndrome. Type 2 is immune complex mediated, which is idiopathic or post-infectious lupus nephritis, HSP, IgA nephropathy. Type 3 is post-immune, that is your immune complexes are not seen here. It is NCA associated idiopathic granulomatosis with polyangiitis and microscopic polyangiitis. So type 1, the anti-GBM antibody disease, also the Goodpasture one. It can be idiopathic also. If plasmapheresis to remove circulating antibodies is helpful in this type of RPGN. The etiology is unknown. The type 2 is the immune complex mediated, can be complication of any of the immune complex nephritis like SLE, IgA, HSP. All of these show granular pattern, characteristic of immune complex, no help with plasmapheresis. Type 3 is posse-immune. So the posse word means lack. So there is lack of anti-GBM antibodies or any immune complexes. Patients do have NCA antibodies, either C or P, and there is a component of vasculitis as well. Clinically, patient will have hematuria with red cell casts in his urine. There is moderate proteinuria. Occasionally it may reach the nephrotic range. Variable hypertension and edema. If the patient has Goodpasture syndrome, he will have hemopsis or even life-threatening hemorrhage in the lungs. So the diagnosis is made by serum analysis for anti-GBM antibodies or NCA antibodies or ANA. There is progressive renal involvement, and eventually patient will have severe oliguria, but the renal function will be recovered after normal therapy. So these are crescents which are formed. This is a proliferation of, if you compare to the left one, there is proliferation of the parietal epithelial cells which are forming the crescents. Again, there is a crescent. This is the left side, your normal, and there are crescents present. This is like moon-like. Crescent means moon-like. Morphology: there are enlarged and pale kidneys, often with hemorrhages on the surface. Focal and segmental necrosis adjacent to glomerular segments uninvolved by proliferative changes. But this is seen in posse-immune, because in these one where the proliferations are occurring in the first two types, you will see immune complexes and hence inflammatory or proliferative changes will be there. But in posse-immune type, you have focal only changes or segmental changes because there is no inflammation or proliferation. The distinctive crescents are formed by proliferation of parietal cells, and monocytes and macrophages are going there. Maybe neutrophil lymphocytes also may be present. The crescents can obliterate the space and compress the tuft. On immunofluorescence, you will see granular immune deposits. In Goodpasture syndrome, you see the linear GBM fluorescence for immunoglobulins and complement. And obviously, posse-immune will have no or little deposition. Electron microscopy discloses the deposits in those cases due to immune complex deposition, which is in type 2. Now coming to the nephrotic syndromes, we know what is nephrotic syndrome. It is when patient has massive proteinuria, more than 3.5 grams per day. Patient also has hypoalbuminemia, so that was selective proteinuria. And there is generalized edema, there is hyperlipidemia and lipiduria. So primarily glomerular diseases. This is the age-wise occurrence. If you see, minimal change disease is the one which is most common in children. 75% of the cases are occurring in children. First is the membranous nephropathy. It is more common in adults. It is characterized by diffuse. So membrane thickness is increasing. It is characterized by diffuse thickening of the glomerular capillary wall due to the accumulation of deposits which contain immunoglobulins along the subepithelial side. So again, the subepithelial deposits are subepithelial immune complex deposits are happening, and they are causing the thickening of the wall. 75% of the time it's idiopathic, which is the primary disease. Then the 25% of the times it can be associated with other causes like drugs, tumors, SLE infections, other autoimmune disorders. So the pathogenesis is chronically there is immune complex deposition. There can be an endogenous cause or an exogenous cause. The endogenous antigen can be renal or non-renal. For example, if it is associated with SLE, so it will be self-nuclear, the antibodies are against your own proteins, and these are autoantibodies. And another example is neutral antipeptidase. And just remember the name of these. Exogenously, there can be hepatitis B virus and Treponema pallidum, which can cause this. Treponema pallidum is the organism which causes syphilis. Clinically, there is insidious onset. Non-selective proteinuria is occurring, does not respond to steroids, hematuria and mild hypertension may occur. Rule out the secondary causes first. It has variable indolent course. Remission can occur in 40% of the patient, but there is possibility of progressive disease, and it will progress to renal failure or kidney disease, chronic kidney disease or end-stage kidney disease. Sometimes patients, if they have proteinuria in the non-nephrotic range, they can have spontaneous remission and a relatively benign outcome. This is your silver stain on the right side. This is your silver stain, which is showing the membrane thickening. So morphology, if you see the morphology of this disease on LM is your light microscopy. In early stages it will be normal, or you will see there is thickening. So the name indicates whenever there is a word called membranous, it means there is diffuse thickening. There is thickening of a membrane. So your glomerular capillary wall is thickening diffusely. On electron microscopy, you can see the immune complexes are deposited. The thickening is occurring because there is immune complexes deposited between the basement membrane and the epithelial cells. So it is subepithelial deposition. Basement material is laid down between these deposits, appearing as irregular spikes protruding, and these are seen on silver stain like in this picture. They may have dome-like protrusions, burying them within the mildly thickened irregular membrane. And on immunofluorescence, there are granular deposits which contain both immunoglobulins and complement. There may be initially just segmental involvement, and eventually it will have total sclerosis. Now the last entity for this PPT is minimal change disease. It is the most frequent cause of nephrotic syndrome in children. It's not that common in adults. Whenever there is minimal change disease, you know it's occurring in child. It's occurring in a child. Peak incidence is between 2 to 6 years of age, maybe after a respiratory infection or after vaccination. So these are on the left side. You see your normal glomerular basement membrane. On the right side, you see that the epithelial, your podocytes are effaced or they are detaching. So what is the classic presentation? The classic question for minimal change diseases that there is a 3 or 4 year old child on light microscopy and electron microscopy. There is no problem, but he is having symptoms. What do you think is the cause? That will be minimal change disease. On light microscopically, there is no problem. Normal glomeruli. Electron microscopically, GBM is normal. There is no deposit material. The principal lesion is that there is uniform and diffuse effacement of the food processes, which we see. The visceral epithelial changes are completely reversible after steroids, and there is something called as lipid nephrosis. So this is when the cells of the PCTs have lipids and proteins. So that means the tubules have reabsorbed these lipoproteins which was passing through the diseased glomeruli. So because the glomeruli are now diseased, the food processes are now effaced. So lipoproteins which should not have passed through the glomeruli are now passing, and now tubules have reabsorbed them. And this is called lipoid nephrosis. That's the second name of this disease, minimal change disease. Again, on immunofluorescence also, there is no immunoglobulins or complement deposition. So clinically, it's a child presenting with massive proteinuria, highly selective. Most of the protein is albumin. There is no hypertension or hematuria. But a characteristic feature is the patient has amazing response to steroids. They will respond positively 90% of the time. The long-term prognosis is excellent. So we will discuss the rest of the entities later. So these were the main entities that we discussed, which is minimal change disease. Again, a child presenting with nephrotic syndrome, severe proteinuria, and a child is presenting, but there is no problem on light microscopy, no problem on electron microscopy, no problem on immunofluorescence. Then we have the membranous nephropathy. So there are subepithelial deposits, immune complex deposition along the glomerular capillary wall, which is causing thickening of the membrane, thickening of the glomerular capillary wall, and it is usually idiopathic. It has usually insidious onset, and again you will see these irregular spikes on silver stain. And then we also discussed this is what is nephrotic syndrome, and then we discussed the crescentric one. So these crescents that you see in the RPGN, and the three subtypes that it has: anti-GBM antibody disease, immune complex mediated, and post-immune type. And then you have the post-streptococcal glomerulonephritis. I hope you understood all of this. I understand that it looks a little complicated. That's why I've put half and half. So some entities I've put here, the others I'll put later on. Thank you.